Hello, everyone. Thank you for joining us today. I'm Linda Mitchell, CEO of Allergy and Asthma Network. Welcome to this afternoon's webinar where we're in for a real treat with Dr. Alice Hoyt here to talk to us about allergies and asthma during the spring. We have a few housekeeping items that I'd like to start off with today's program. First, all participants will be on mute for this webinar. We will be recording this webinar and we will be sharing the link to the recording and some other resources in a day or two after this webinar is concluded. Regardless, you can find all of our recorded webinars on the allergy-asthma-network.org website. If you just go to our homepage, scroll down, you'll see all the upcoming webinars and then links to the recordings of the others that have preceded it. This webinar will be 1 hour in length. That includes time for questions. So put your questions in the question box in the Zoom platform. And if you need any help, we have assistants available to you. So you can go ahead and just put in the questions you may have in the questions box or just any other questions you might have about technical assistance or whatever in the chat box. We will not be offering continuing education credits for this webinar, but we do have a certificate of attendance available if you need it for your records. And we'll try to add a link to the certificate in the chat box so that you can try to access this during this live presentation. So let's get started. Today's topic is spring allergies and asthma. Spring is on its way. That means sunny days and allergies. In this webinar, you'll learn about the ways that seasonal allergies may trigger asthma symptoms and how you can manage that this time of year and hopefully proactively. It's my pleasure to introduce our speaker, Dr. Alice Hoyt. Dr. Hoyt is the Chief Allergist at the Hoyt Institute of Food Allergy in New Orleans. She has been practicing academic, evidence-based medicine for over a decade. Dr. Hoyt is board certified in internal medicine, pediatrics, and allergy and immunology. During her fellowship at the University of Virginia, Dr. Hoyt launched a new, and at the time, national allergy-focused nonprofit organization, the Teal Schoolhouse, supporting the Code Anna program, which teaches medical and non-medical school personnel and childcare providers about medical emergencies. At Vanderbilt University, Dr. Hoyt continued her food allergy focused efforts before transitioning to the Cleveland Clinic, where she helped launch the Food Allergy Center of Excellence there. Dr. Hoyt decided to bring her food allergy expertise to families in her home state of Louisiana, and she launched the Hoyt Institute of Food Allergy. In addition to leading the Institute, Dr. Hoyt hosts a top-ranked food allergy podcast called Food Allergy and Your Kiddo and chairs the Code Anna nonprofit organization. And Dr. Hoyt recently was named Practice Champion of the Year by the American Academy of Allergy, Asthma, and Immunology. Congratulations, Dr. Hoyt. I know that's a really big deal and a big honor. So with that, I'm going to hand it over to you to get started. Thank you so much.
Thank you, Linda. Thank you so much for having me. I see someone's from Zachary, Louisiana. All right, Zachary, Louisiana. Again, Linda, thank you so much for having me. I love doing these webinars with Allergy and Asthma Network, and this is just such a perfect topic for right now. And I was getting in my car. Clearly, it's covered in pollen. So I'm going to go ahead and share my screen, and we're going to get going here. Okay. Are we good? Are we sharing a screen in a good way, Linda?
Yes, I think you have to put it on slideshow format, but it is working.
How does it look now?
It's perfect. Thank you.
Okay, awesome. Awesome. Well, again, thank y'all so much for having me today and for that really lovely introduction. Today, we are talking about, and I'm trying to move the Zoom bar. Y'all know how it is. We're going to be talking about allergies and asthma. And again, thanks again to the network for having me. Go ahead, and if you haven't already, put in the chat what your interest in seasonal allergies and asthma is. Are you a patient? Are you a parent? Are you a healthcare professional? And if you are, what type of healthcare professional or something else? Are you a school nurse? Are you a concerned aunt? And also put the name of your state, and that will become relevant in a little bit. So I wanted to start this presentation by something that when I learned it as a fellow, it was kind of a no-brainer, a fellow in training. It was kind of a no-brainer, but it it has stuck with me. And I love how Barry Cohen just last year in pediatrics took this that we've known for years and put it into a beautiful quote. Untreated allergic rhinitis in children increases the risk for poor asthma control, increased asthma severity, and exacerbations. So let me say that again. Untreated allergic rhinitis, so untreated itchy, drippy, sneezy, ultimately can worsen asthma. So that's why it's so important that we're talking about this topic today, so that we can really respect those allergies. Sometimes I feel like the itchy, drippy, sneezy doesn't get the respect it deserves. And if we can get that under control, then that can help so much our lungs. So after today's session, you will be able to do the following 3 things. Number 1, you will be able to define seasonal allergies and allergic asthma. Number 2, you will be able to describe how these allergies impact asthma. And number 3, you'll be able to really discuss management strategies for seasonal allergies and for allergic asthma. And this is important whether you are a patient or a provider or somewhere in between. So let's start with the case, because I think we all learn better if there's some sort of clinical case that we're tuned into. So here's Daniel. He is a 6-year-old boy from New Orleans. He has no chronic medical issues, and he presents to an allergist this time of year with the following symptoms: runny, itchy nose, nasal congestion. His symptoms are worse in the spring and at his friend's house. And by the way, his friend has a cat. And the allergic salute is present. No, not that salute. The allergic salute, as you can see on the screen, you see the little arrows pointing where you get a little line actually from your nose running so much that you just keep upping, and it actually forms like a little wrinkle, forms a little line. So that is the allergic salute. And he was seen by the allergist. Skin prick testing was performed, was positive to multiple allergens. So what is his diagnosis? Allergic rhinitis, seasonal allergies, absolutely. So what really are allergies? The term allergies is often short for the condition allergic rhinitis, or also called hay fever. Allergic rhinitis symptoms, they can include runny nose, nasal congestion, itchy nose, sneezing, and also fatigue due to poor rest. Allergic conjunctivitis is allergic inflammation of the eyes, and that presents with itchy, watery red eyes. And allergic rhinoconjunctivitis is a mixture of all of those things. And y'all, look how many people have this. 25.7% of adults and 18.9% of children have seasonal allergies. That is bonkers. That is a lot of people. And when we think about seasonal allergies or allergic rhinitis in general, one of the questions I often get is like, well, how do you know it's allergies and it's not just a cold? The biggest component is really that itch component, because when you have seasonal allergies and you're being exposed to pollen, breathing that in, whichever pollen it is, when you breathe that in, it activates your little allergy cells, specifically mast cells, M-A-S-T, mast cells. Those cells get activated and they release histamine, and histamine is a very itchy chemical. They release other stuff too, like vasodilators, meaning your vessels open up. So that's where like the runny nose comes from. But when you're having that itchy, drippy, sneezy, that is allergies. So what are common allergens in allergic rhinitis or allergic rhinoconjunctivitis and ARC, whatever we want to call it? Really, the allergen, it's a protein, and it binds to allergen-specific IgE, meaning it binds to the little allergen antibodies that are hanging out on those allergy cells, on those mast cells, and that binding triggers allergic inflammation, mast cell degranulation. It activates your allergy cells, basically. And allergens can be mold, pollens, danders, dust, and cockroach. And here we have a beautiful, beautiful cockroach. And why I also included the little rainbow colored poo-poos in the potty is because the allergen of a dust mite allergy is actually their poop. And so I thought that was the most kind of the loveliest way to depict that. I can't wait to see the comments in the chat. And Linda, if anything, any big comments come in or anything that you want to interrupt me, please, by all means, feel free to do so.
Okay, thank you.
I love maps. And so I really liked having this depiction here, and think about where you are and think about the different allergens that could be going on. So here we are in March. It's actually Pi Day 3.14. And so where I am in Louisiana in March, we're having some grass pollen already. We're well into our tree pollens. And you can look at these maps and see, okay, well, what kind of pollens really are we dealing with at what time of year? Now let's talk about treatment for allergic rhinoconjunctivitis or seasonal allergies. There can be lots of different therapies and some work better for different people. So this is why it's really important to have a board certified allergist to help talk you through which therapies could be best for you. So the first type of therapy would be a behavior modification, really trying to avoid certain allergens. After you're outside in allergens or a lot of pollen, then taking a shower, getting a lot of that off of you, especially if you're doing yard work, and then also using air filters. Air filters have really come a long way and do help remove a lot of allergens from the air. So that's one thing to do, but really like allergen avoidance, that can be pretty difficult, right? And it's kind of like my job as an allergist to help my patients live their lives how they want to, and I help control those allergies. So then that kind of brings us next into medications. And medications can be over the counter, very simple medications, or there can be some prescription medications. We can talk about nasal and eye rinses, really just rinsing out our eyes, rinsing the pollens out of our eyes, rinsing the allergens. I shouldn't just say pollens, but really rinsing the allergens out of our eyes and clearing our nose. One of the most important parts of our nose is it really tries to stop those allergens up here before it can go down into our lungs. So rinsing our nose with sterile water or with saline. I really like the saline sprays that can really just help clear stuff out. Next, nasal steroid spray. Nasal steroid sprays are actually first-line treatment for allergic rhinitis. A lot of people think that an antihistamine is, but really these nasal steroid sprays are super powerful. And you're probably thinking, wow, well, how can a nasal spray be super powerful? It's because it's steroid. And the reason it's this nasal spray form of steroid is because steroids are incredibly potent at decreasing inflammation. But we know that if you take steroids by mouth, they can have a lot of bad side effects. Sometimes you need to have them for an asthma exacerbation or other things, but they can really long-term have some pretty bad side effects. They can affect your bones, they can affect your weight, they can affect your body habitus, how your body actually looks. They can affect your attitude, your appetite. They can do some pretty nasty things. So it was super high tech and futuristic when steroids were then put into a nasal spray, because then they go right to the site of the inflammation. And I'll take a moment right now to show you guys how to use the nasal spray just by looking at this image on your screen. One of the downsides of nasal steroid sprays is that the steroids are super potent. And if you spray steroid on the bone inside your nose, like if you spray it this way, then it can cause a lot of irritation and even perforation and nosebleeds. So when you use a nasal steroid spray, you really want to use it like this woman on the picture is using it, where you're not pointing it towards the septum or to the bone in the middle of your nose. You're actually pointing it kind of towards that ear on that side. So if you're in your right ear, pointing it more towards your right ear, not pointing it towards the middle. And also some of the nasal steroid sprays are more of a mist and less of a squirt. And those are the ones that I recommend for my patients. Moving right along to oral and eye drop antihistamines. They can also be very helpful. Leukotriene receptor antagonists, and then also some eye drops that actually kind of stabilize those allergy cells so that they don't become activated, because when they become activated is when those blood vessels get red and you have tearing and it's itchy. I also get questions like, oh, well, how do I know if I have dry eye or allergies? Dry eye is really more of a gritty eye. And with dry eye, you can actually have tearing. One of the causes of dry eye is you get tears that have more of the water part of the tear, but not enough of like the lubricant oily part of the tear. And so since you're not lubricating your eyes enough, that's why you get the grittiness, not you not lubricating, but your tears are not doing that. And that grittiness is very different than the itchiness that is felt when the allergy cells become activated. So then the third type of therapy that we should talk about here is subcutaneous immunotherapy and sublingual immunotherapy. And it's called immunotherapy because you're actually making changes to the immune system to grow tolerance to the allergens. Subcutaneous immunotherapy is allergy shots, and sublingual immunotherapy is tablets or drops under the tongue. So let's get back to Daniel. What we decided to do for Daniel for his allergic rhinitis was start nasal rinses. He was on board with this, right? It's a 6-year-old. We got to get him on board. The nasal rinses with the saline mist to rinse out all the yucky stuff, and then use the nasal steroid spray. So it can be very helpful just doing that rinse before you do your nasal steroid spray, because then that steroid is really getting where it needs to go. We talked about doing an antihistamine, and he can do that more as needed, or do it for the first week while starting the nasal steroid spray, because the nasal steroid spray is not an immediate fix. The immediate fix nasal sprays, y'all, you want to stay away from, because those cause immediate vasoconstriction, or Afrin. I'm sorry, I can't remember the generic name, but it causes immediate vasoconstriction to stop the runny nose. But then when it wears off, you can have rebound runny nose and get worse runny nose. So then you do it again, and you can also actually become addicted to those types of nasal steroid sprays. So we really want to limit the use of those. So maybe put them on an antihistamine, a non-drowsy antihistamine. The first generation antihistamines like Benadryl or diphenhydramine, we really don't see a use for those anymore because we have other antihistamines like Zyrtec, Claritin, Allegra that can work very well, Xyzal, that can work very well without causing so much grogginess. Zyrtec still can cause some grogginess, but not nearly as much as Benadryl. Also, some kids don't respond well to Benadryl and can have some rebound hyperness. Also with Singulair or Montelukast, going down our list, we have to counsel our patients on having some vivid dreams. So you can see how when I'm thinking about my treatment plan for a patient with seasonal allergies, I'm not just thinking, okay, what's the most potent medication I can use here? I'm thinking, one, can the patient do this, right? If I have a patient who is in no way, shape, or form going to put anything up their nose, then I have to accept that and work with the family through shared decision making and go through all of these options. But I'm thinking of what's going to best improve their quality of life while also treating their condition. And that brings us down to SCIT or allergy shots, or SLIT, sublingual immunotherapy. Sublingual immunotherapy, what's so nice about it is that it's not shots, right? Like shots aren't fun. But sublingual immunotherapy might not be as potent as allergy shots. Allergy shots are super tried and true. We've been doing them for decades. And they actually teach the immune system to tolerate the allergen, so that in many cases, if you're on allergy shots for 3 to 5 years, you stop your allergy shots, you're tolerant to the allergen. So you're not needing nearly as much, if any, of these medications anymore. So now that we've talked all about seasonal allergies or allergic rhinitis, let's go into allergic asthma, because I told you when we started that if we get the allergies under control, that can really help the asthma. But what really is asthma, right? Asthma is kind of a catch-all term for conditions that cause reversible airway obstruction. And I say reversible because ultimately, if asthma persists without getting the condition under better control, then it can have less and less reversibility. But in general, asthma is reversible, meaning if someone has asthma, they start wheezing, then they can take a bronchodilator like albuterol, and that will open up their airways. It's reversible. Asthma symptoms can include coughing, wheezing, chest tightness, and shortness of breath. I really don't want to underplay coughing as a symptom of asthma. I know a lot of families that sometimes don't realize that their child is having an asthma flare until they're wheezing, but they've been coughing for the last 2 days. And then suddenly they're wheezing and having worsened shortness of breath. 8.7% of adults and 6.2% of kids have asthma. So then what's allergic asthma? Allergic asthma is when an allergen is triggering the asthma. There are some forms of asthma where allergens are not playing a role at all. And that's really important for me as an allergist to tease out and for my pulmonology colleagues to tease out, does this patient have allergic asthma or not? Because that can really differentiate what type of therapies I'm going to prioritize for that patient. Allergens, just like for allergic rhinitis, can include pollen, mold, danders, dust. And then allergic asthma can also be triggered by viral infections like rhinovirus. Rhinovirus, for most people or people who don't have asthma, I should say, is typically like just the common cold or runny nose, rhino meaning nose. But in people who have asthma, even mild asthma, if they get rhinovirus, they can have significant symptoms, significant asthma exacerbation. And really, asthma exacerbations are all too common. So here's data from the National Health Interview Survey, the national prevalence of asthma attacks among children and adults who currently have asthma. And essentially, of kids and adults having asthma attacks, you can see on the screen that that's a big percentage there. So an asthma exacerbation, to me, that really indicates that a person's asthma is not well controlled, and thus management really needs to be stepped up. So how can we really prevent those asthma exacerbations? Most asthma exacerbations, they really can be prevented if we have good control of the asthma. And that sounds kind of like a no-brainer statement. Like, of course, if your asthma is well controlled, then like you won't have an exacerbation. But unless you really get in the weeds talking with families about a patient's asthma, you might not realize that they are having breakthrough symptoms, or they're having more severe asthma, or they have a more severe case of asthma than what you currently think they do. And that's why thinking about things about coughing at night, is play limited due to shortness of breath that you're just sort of not realizing. This is all very important to consider. Controlling asthma really should include these 4 things, and this was in the Journal of Allergy, Clinical Immunology and Practice back in 2017. The first thing is patient education. I feel like I've already talked so much about the importance of talking with families, and for families to share all the potential symptoms. I've definitely had patients not realize that the coughing was even a part of possibly asthma. They thought it was just wheezing. Monitoring of symptoms and monitoring lung function with breathing tests, control of triggering factors. We're going to come back to that, right? And comorbid conditions. And then, of course, pharmacologic therapy. So when we're thinking about asthma medications, we have a slew of asthma medications now. Inhaled short-acting beta agonists, basically albuterol, or medications that open up those smooth muscle in the lungs to open up those airways. An inhaled steroid. Inhaled steroids help calm down inflammation in the lungs to help prevent those airways from tightening up to start with. Combining those medications, so combined inhaled steroid and a longer acting beta agonist or a longer acting version of albuterol. And as Linda and I were talking before we came on the session about a new medication that's actually inhaled steroid and a short acting, or there's albuterol. And then also allergen immunotherapy. So I talked about shots for seasonal allergies, but I'm also going to talk a little bit about allergy shots for asthma, because if a patient has allergic asthma, meaning they have asthma that is flared by seasonal allergens or perennial allergens, dust mite, cat, whatever the case may be, if you teach their immune system to tolerate their allergens, and if you calm down the allergic inflammation that's being triggered by those allergens, that can actually calm down the inflammation in the lungs and help improve asthma, which can be an absolute game changer. And then moving into biologics, Xolair, Nucala, Fasenra, there's seemingly to me a ton of them now, because when I started in allergy, there were not nearly this many. And really, I remember when Xolair was just approved for children and we were able to start a little boy on Xolair, and it was literally life-changing for him. He had severe asthma. He had significant seasonal and perennial allergies, and he loved soccer, but he was not able to keep up with his friends and really enjoy his soccer because he would get so out of breath and sneeze and cough, and it would flare his asthma. It was terrible. And we started Xolair on him, and within months, he was just running around, loving life, loving soccer, and it was just awesome. And here I want to take a minute and talk about smart therapy, and let's be smart with asthma. And I love on allergy-asthma-network.org, there's a beautiful article written on smart therapy. And probably if you're a school nurse and you're tuning into this session, or an allergy nurse or pulm nurse or peds nurse, really any healthcare provider, if you haven't looked at this, you should definitely look at this article. But actually why I really like it is because it's written in a way that's very easy to understand, and it just makes so much sense and it lays it all out. So what really is smart therapy? SMART stands for single maintenance and reliever therapy. I'm going to stop here for a second. If you have asthma, or if you know someone who has asthma, you might know that someone might have one inhaler. They might just have mild intermittent asthma, and they might just need albuterol every now and then. Or they might have moderate persistent asthma, and so they might have that albuterol inhaler. They might also have another inhaler or a disc, or they might be on a biologic medication. So that can get to be a lot. Having multiple inhalers can be one of the most confusing things. And so what smart therapy is really sort of moving away from that two inhaler approach and actually using what we typically term a maintenance medication like Symbicort or like Dulera as a rescue. And so how this works is smart therapy is a combination of an inhaled steroid and a long-acting version of albuterol. So in this case with smart therapy, formoterol is that long-acting version of albuterol. But what's so nice about formoterol compared to the long-acting albuterol found in Advair is that formoterol starts working quickly, just like albuterol starts working quickly, just lasts longer. And so what studies have shown and why smart therapy is so nice is because you can just kind of get rid of your albuterol, just like getting rid of your Benadryl, because that's not helpful. Get rid of your albuterol and just use your maintenance inhaler. And so this can be very helpful. In my opinion, this can help with adherence to the provider's intended medical plan because it's not confusing. It's also adherence because you're more likely to have the medication with you. Anyone who has kids with asthma knows, like, you need to have their medication with them at all times because you never know when they're going to start having shortness of breath or coughing or a flare of their asthma, right? So So you want to have everything you need. And as you see on the screen, if you have kids, that's not just the inhaler, that's also going to be the spacer and the mask. And even if you don't have kids and you're here as an adult and you're learning about asthma, or you have more adult kids, using that aero chamber, that spacer, just without the mask, just a little mouthpiece, that helps you get the medication you need into your lungs, as opposed to just trying to use the space or just trying to use the inhaler and coordinate the puff and the breathe. And it's just too much. Like, use a spacer, and it's much more effective. And that's what we want, right? Effective. But a medication won't be effective, one, if you don't like use it properly, but two, if you don't have it at all. And so what smart therapy can do, it can really just simplify the asthma regimen. Also love that Allergy and Asthma Network has this asthma action plan. So as somebody who sees lots of kids and kids who have asthma and wants their school to be well-informed and up to date on what their plan is, should they start having any even very mild flare of asthma at school, I love that this asthma action plan is for smart therapy. And you can find this on the Allergy and Asthma Network website. And ideally, these types of plans should be completed with you and your kiddo, or with you, your teen, or if it's you, you still need this type of plan. It's still so much easier if you have a written down plan from your doctor when you start having an asthma flare, whether you're a grown up or a kid. But it's really nice to sit down with your doc and go through this, because it's a way to make sure, for me, it's a way for me as a doctor to make sure that I can see that my patient, their family, they understand this plan, as opposed to me just receiving the facts from the school or from the email from mom and then just faxing it on. I really like that closed loop communication where we're sitting down, going through each step of this to make sure everyone is well aware of when and why to use what medication. This is also very important. One more thing, I call this a tangent on my podcast. One more thing. This is very important when we're thinking about the transition from the pediatric care model to the adult care model. When you, as a patient or a family, or as a doctor, healthcare provider, whatever, when you're talking through this and talking with a child, making sure that they're understanding when and how to use their medications, that can start as early as preschool, of making sure that they know that if they start feeling badly, to ask for their medication. My daughter is 3. And she will ask for her breathing medication when she feels like she needs it. So we can teach kids to recognize symptoms, first of all, and ask for help, and start to know what is going to help them. So again, just a big plug for this type of action plan and filling it out, and this specific action plan from Allergy and Asthma Network, and filling it out ideally with a healthcare provider. So now let's fast forward to Daniel. Here he is 7 years later. He's now 13 years old, and he continues to have allergic rhinitis and he developed asthma 4 years ago. He presents for follow-up with his pediatrician. Good, he's following up. He went to the ER recently for an asthma exacerbation on Easter. So his medications include the combined inhaled corticosteroid long-acting beta agonist, the ICS-LABA, and as needed albuterol. So this is not smart therapy, right? He also just completed a steroid burst that he was given in the emergency room. He occasionally uses nasal steroid spray, and he tried allergy shots a couple years ago, but then he stopped 4 months in because he's a busy dude. I mean, look at him. He's a musician. He's super involved in school. But total bummer. I mean, he had an asthma exacerbation on Easter. That's not what he planned for spring break. So what may be the primary reasons his asthma flared when it did? Well, let's think about this. He still lives in New Orleans, right? And really how allergies impact asthma. So here he is, the red circle circling Louisiana, and Easter this year into March, let's say March, April, and you can really pinpoint what could be triggering his asthma. You also want to ask about any illnesses recently. Has anyone else been sick? Because this can clue us in to, is a kiddo having rhinovirus, or did they have RSV? And is that really tipping over their asthma? Well, here are his allergens, those dust mites and that cat dander. So that's no good down here. And to really drive this point home, y'all, it's all one airway. So simply stated, allergic inflammation in the nose can absolutely trigger that inflammation here in the lungs. And on the screen is a very fancy scientific way to demonstrate that. I am not going to belabor this, but there are complex immune mechanisms that do this. So what treatments may work well now for teenaged Daniel? I want to go back to that quote that we had in the beginning. Untreated allergic rhinitis in children increases the risk for poor asthma control, increased asthma severity, and exacerbations. So one of the easiest things we can do for Daniel is to treat his allergies too. So let's discuss that. Let's discuss management strategies for seasonal allergies and allergic asthma. So what really should we use? So I love tables. So here's a nice table comparing what we use for allergic rhinitis, seasonal and perennial, and what do we use for allergic asthma, severe, persistent, poorly controlled allergic asthma. For that allergic rhinitis, again, we can do that nasal saline rinse. Just rinse all the pollen out, all the cockroach stuff, all of the cat dander, just rinse it all out. Cat dander, for those of you that don't know, is it reminds me of Pigpen from Peanuts. You know, Pigpen has all that like dirt cloud all around. That's what cat dander does. One of my mentors in fellowship said it was weaponized because it is just all around, as opposed to dog dander, which is a heavier allergen and it more so falls to the ground and can absolutely be found in house dust. But that cat is just like, oh, that's why you can tell if you're allergic to cats, you can tell if one of your friends that has a cat, when they come in wearing a sweater and you start sneezing, it's because they've been snuggling their cat. Their cat has left that dander on their lovely owner, and now they have that cat dander cloud all around them. So you want to rinse all that stuff out because you breathe it in. You want to rinse it all out. And you can do that with the saline rinse. And also, whenever you're doing any sort of nasal rinse, if you're not using a sterile saline spray and you're using tap water, you definitely want to have boiled the tap water, let it cool before you use it to do rinses, because you don't want to have a potential infection from that. Nasal steroid spray, right? He's only kind of maybe using it sometimes. Plus or minus an antihistamine, and really allergy shots for him, maybe. Allergen avoidance, you can't always avoid some of this stuff, right? So that's for allergic rhinitis. And then let's think about allergic asthma. Really the smart therapy. For him, absolutely, he needs smart therapy. Maybe he'd be interested in allergy shots. And then also potentially a biologic for him. I really don't like to downplay any sort of emergency room visit for asthma, especially not, which Daniel does not necessarily have food allergies. We did not write that in the case, right? But if Daniel did have food allergies, then we always want, specifically IgE mediated or an anaphylactic food allergy, we want to be very mindful of those patients who have food allergies and asthma, because if they were to have an accidental ingestion of their allergen and have an allergic reaction, well, if they have poorly controlled asthma on top of that allergic reaction, that sets them up for a bad outcome. Asthma itself is a risk factor for a bad outcome in people who have food allergies. So we want to really look at him as comprehensively as possible and make a treatment plan that is going to be, first of all, that he's going to do, right? That he will adhere to these recommendations, but also that's going to best treat his conditions. Okay, wait a second. What if Daniel told you that biting into fresh apples caused a tingly sensation in his mouth and that he develops mild lip swelling? What could this be? This could be what's called oral allergy syndrome. Oral allergy syndrome is a type of pollen food allergy syndrome. Pollen food allergy syndrome is when you are allergic to a specific pollen, but that pollen protein looks a whole lot like some other food proteins, so that then when you ingest the other food protein, then your body thinks you're ingesting the allergen and you have an allergic reaction. So this is a super cool, I think, visual from uptodate.com, where you can see if you're allergic to birch pollen, which he is having itchy, drippy, sneezy during a time where trees are blooming. And so the tree pollen is floating through the air. He's breathing it in, triggering his seasonal allergies, triggering his asthma. Well, it's not surprising that if he bites into a fresh apple that has proteins that look a lot like birch pollen, that he's going to have sort of like a local, itchy, unpleasant sensation. And then the enzymes in his saliva and ultimately gastric juices just sort of break down that protein enough where it's not causing anaphylaxis. Oral allergy syndrome, by definition, is limited to the mouth, the oral pharynx. And so you're not having anaphylaxis from oral allergy syndrome. The treatment for oral allergy syndrome is to avoid the food, but really these people tend to really like the foods that are triggering their reactions. So since this is oral allergy syndrome, you can allow them to continue to eat it, or they can avoid it, or they can cook the food, or they can take an antihistamine. There's not a double-blind placebo-controlled study on this, but patients have told me that swish and spit antihistamine can help pretty promptly. So sort of wrapping up now, you should now be able to define seasonal allergies and allergic asthma, describe how allergies can impact asthma, and really discuss management strategies for seasonal allergies and for asthma. I want to thank y'all so much for having me. I love the Allergy and Asthma Network. Their resources are fantastic. Here's my social stuff. Next webinar, it's me insect venom, and I'm going to turn it back over to Linda.
Thank you, Dr. Hoyt. Just wonderful. I got a bunch of questions I'd like to kind of run by you so that you can help out. And somebody just asked for the link to your podcast. Can you put that up again so everybody can see? There you go.
Yes. foodallergyandyourkiddo.com. And we're on all the podcast things.
Okay, great. So can you explain mist versus spray, and is one better than the other in terms of nasal sprays?
Yes. So mist versus spray, depending on and Linda, I can just talk about the real names of the drugs, right?
Yeah, here, this is
Okay,
not a
thanks.
CME webinar. Yeah.
Thank you. Sometimes y'all with continuing medical education, with doctory things, they get really funny about us using brand names. But basically, when you go to the allergy aisle, very overwhelming, for lack of a better word. But you can see Flonase, which is sort of more of green and white packaging. And then you can see Flonase Scentsy Mist, which is blue and white packaging. Regular old Flonase is more of a squirt. And it has sort of an interesting taste smell to it. And you can kind of feel it kind of trickling down the back of your throat, as opposed to Scentsy Mist, which is a very similar inhaled steroid. So the actual medication is incredibly similar, but it is more of a mist when you squeeze the device. It's more of a puff, more of like a little mist cloud in your nose. It doesn't have nearly the like weird taste smell thing going on, and it stays more where you want it to go. And so we feel that it is more effective because it's getting where it needs to be. It's staying where it needs to be. People are more likely to use it. Again, coming back to adherence, people are more likely to use it because it's sort of just less abrasive. And we find that there's less adverse effects, less nosebleeds, because it's more of a puff as opposed to squirting steroid.
Okay, great. Yeah, I switched to Scentsy Mist myself, so I know what you're referring to. It's easier it stays where it's supposed to, as opposed to running down your
Right,
out of your nose.
right.
Yeah, so the next question was about nosebleeds, but I think you you addressed that. I don't know if there's anything else you want to say about avoiding nosebleeds and
Just even though these medications are over the counter, if you have had nosebleeds or your kiddo has had nosebleeds, talk with your allergist before starting one of these meds.
okay, great. We have a lot of school nurses on the
Yay.
Zoom webinar today. I know you love school nurses. So I'm just wondering, in terms of them supporting their students and the students' families in terms of education or whatever, can you just kind of give some tips about what they could do as a school nurse to help kids who have, say, allergic asthma and they know that this is allergy season and they're suffering? And anyhow, I'll just kind of let you take it from here.
Yeah, no, absolutely. A lot of families, and even a lot of healthcare professionals, some pediatricians, family docs, internists, don't really recognize how strong that connection is between seasonal allergies and asthma. So if at any point you as a school nurse are calling a parent about an asthma exacerbation, wheezing, then definitely mention to them, hey, it's allergy season and seasonal allergies can definitely trigger asthma. So if you haven't talked to your pediatrician about this, or if you haven't seen an allergist, this might be something you want to consider doing, because the data shows that getting the allergies under control can certainly help the asthma, and that can put the bug in their ear to ask their doctor about it.
Great, thank you so much. Does Xyzal cause drowsiness or is it one of the non-sedating
That's a really good
treatments?
question. Only a few of them have the actual like non-sedating a label. And I don't think Xyzal actually has that non-sedating label. It is less sedating than definitely less sedating than diphenhydramine, but really it's the Allegra and Claritin that are much more like non-sedating. So I'm sorry, I'd have to check what the actual label says. Sometimes they change these things.
No problem. Um, how long does Symbicort take to work compared to, say, other combination inhalers? I know it's kind of different, but if you can explain that for everybody.
So other combination inhalers, and this gets to, let me go back. I'm sorry if this is, there we go. Symbicort has budesonide, which is the inhaled steroid, and it has formoterol in it. And so it's going to work regarding opening up the airways. It's going to work pretty promptly. It has that inhaled steroid, so it's also going to help calm inflammation. That's different than the inhaled steroid, or that's different than the long-acting like version of albuterol found in Advair, because it doesn't work as quickly. So if we're talking about how quickly is Symbicort going to open the airways compared to albuterol, it is pretty equivalent, and that's why smart therapy is so nice. But Advair does not have that equivalence. Advair's long-acting albuterol takes longer to work. And so that's why you don't want to use Advair for smart therapy, because you're not going to get that rescue open up that you get from albuterol or from formoterol.
Okay, great. Thank you.
Mm-hmm.
So this was a really interesting question. So for kiddos that have exercise-induced bronchospasm, what do they do for needing, say, to pre-treat before exercise if they're using smart therapy? Do they just use that, or is there some other way that it's handled?
That's a really good question. So if you are really limited to exercise-induced bronchospasm or exercise-induced asthma, and you really at no other times have any other asthma, then this is a time where you can consider continue your albuterol, or you can consider the new albuterol and steroid. But if you really only get exercise-induced bronchospasm, then we're not thinking there's like a whole lot of inflammation there in your lungs. It's sort of a different mechanism of action. So then you don't necessarily need that steroid. So then that comes to smart therapy. Like, do you necessarily need that steroid? Not necessarily, right? This is definitely a time, if you're dealing with exercise-induced bronchospasm, it is a great time to get back in and talk with your allergist and really be very detailed about your symptoms, when your symptoms are, because also a lot of exercise and sports are in the spring or in the fall, and symptoms can change along the way. So that's why I say, as new therapies come up, get plugged back in with your allergist and talk through, is this a good treatment option for you?
Okay. Let me see. Do children need to wash their mouths after using albuterol? The nurse was saying, I know about the inhaled steroids, but how about albuterol?
That's a really good question. The reason we like kids and adults to rinse their mouths or brush their teeth after using an inhaled steroid is because the steroid can there can be residual steroid left in the mouth, and that can promote thrush, development of thrush, and we don't want that. We don't see the same effects really with albuterol because it doesn't have the steroid in it.
Okay, great. Next question, are products like Navage, Neti Pots, and other sinus washes recommended to deal with allergic rhinitis?
Yes, yes. So my sort of like 3-step, and there's still an old Facebook video from when I was at Vanderbilt about this, is number 1, rinse your nose out. Number 2, use your nasal steroid spray. And then number 3, an antihistamine, but really that antihistamine is third, which tends to rock people's world. And number 1 is rinsing your nose out. And so doing that type of neti pot or lavage, some people, first of all, you really want to you have to use sterile water. Don't just put water under the sink and do it, because there is still a risk of severe infection if the water has any sort of bacteria in it. So you want to use sterile water, and yeah, you can use those devices. Some people feel like those devices, like they're drowning, and some people don't have the time to deal with the boiled water or the sterile water or all that stuff. They really just want something that they can take on the go. And that's where those sort of aerosolized sprays of like it's like Simply Saline is the brand name, to really just spray a bunch of it in the shower or over the sink. And then you just kind of like let it all come out, and it helps get all the yucky stuff out, get the pollen out, get the dander out, because if the pollen and the dander aren't there, then they're not going to keep triggering those allergy cells. So you want to rinse that out. And then you've got sort of like a clean surface to then put that nasal steroid spray that then really helps calm down the inflammation. So yes, I do think that those types of devices, when used properly, can be helpful.
Okay, great. So you brought up the reference to Benadryl. And so a question is, should we be staying away from Benadryl altogether, or is it still recommended for allergy flare-ups when taking a daily med?
I do not see a need for Benadryl at all anymore. It served a good purpose before we had longer acting, less sedating or non-sedating antihistamines. But now that we have medications that work just as well from an antihistamine standpoint without the adverse effects, I do not see a role for Benadryl. If you mean that you're doing your nasal rinses, you're on a nasal steroid, and you've already taken a Zyrtec that day, can you take another Zyrtec if you're at your friend's house and just the cat is just driving you crazy? Like, yeah, you can take another Zyrtec. And actually for chronic hives, patients with chronic hives, we double dose more than that sometimes for patients who have chronic hives for antihistamines. But again, once you're getting into that type of significant symptomology and you need more advanced therapy and you need more help to help control those symptoms, you want to customize your plan with your allergist.
That's great. What's been your experience on getting smart therapy paid for by insurance? Has that been pretty much adopted as acceptable in the payment tiers for insurances, or are you finding that it's spotty?
It's the inhaler situation is I feel like it's ever changing. Regardless of what your insurance is, something can be approved today and it's not the next. But I have not found significant issues with it, but I am a more recent adopter. I have not heard my colleagues say that they're not getting that approved, but that's absolutely going to be something for us as docs and as advocacy organizations to continue to monitor. I think that's a really good point.
Yeah, we do a lot of advocacy. In fact, we have a link on a page on our website about what can you do if you can't afford your asthma medications. And one of them is a link to AstraZeneca's website regarding Symbicort. So
Awesome.
just wanted to, we can include that in the follow-up email as well, but you can actually find it if you just go to our website and look under the asthma section. It's a whole page there. You can scroll down and find Symbicort. And I'll try to put the link in the chat here so that you can see that as well. Let me see if I can find
Yeah,
it.
your website, the Allergy Asthma Network website is just has so much very good information.
Well, thank you for that. Yeah, I really appreciate it. And also, I should just let everybody know, we are in the process of developing one-page handouts written at the grade 5 and 6 reading level on all sorts of topics regarding asthma, allergies, and related conditions. They're also going to be in Spanish. Some of the asthma ones are already ready. And when we get them all finished, we're going to put them in our online store as free downloads so that you can print them out and use them with your students or families so that they can have that information that's readily available.
That's awesome. That's another, to go back to the school nurse question, that's a great way to get that information into the hands of parents. That's awesome.
Absolutely. Oh, thank you, Chris. She just put the link to what if I can't afford my asthma medication in the chat. And if you just scroll down, you'll find the information about Symbicort and AstraZeneca. I have seen somebody posted, I have seen recently a nasal antihistamine spray. How do they factor into treating allergic rhinitis?
Nasal antihistamines in general, they're going to stop the histamine once it has been released by the allergy cell. And that is why we don't say, well, give an antihistamine if you're having anaphylaxis, because antihistamines are just going to help the histamine. And there's a lot more going on in anaphylaxis than just histamine being released. Well, it's the same thing in seasonal allergies or allergic rhinitis, is it's more than just the histamine. And that's why using more than an antihistamine is going to give you the best effect. And that's really why the nasal steroid spray is the first line, because that steroid calms all of the inflammation, not just the histamine.
Great. And I'm going to give you one last question. So what's the deal, if you can explain for everybody, if you treat allergic rhinitis and it helps with eye allergies?
Oh, so that's a really good question. Really, you're just calming down all of the inflammation. Now, there is some communication via tear ducts from your eyes down into your nose. And that's why, like, when you start tearing up, you start also sniffling. And so sometimes some of the medication we think can sort of traverse to help calm inflammation up there. But really, it's just a matter of, if you kind of calm down the source or the mothership of it all, and when you're breathing in allergens, it is hanging out right there. You calm all that down. It calms down the allergy inflammation throughout.
Well, thank you so much. This was really wonderful. I wish we had more time with you, but we're at the top of the hour. So I'm just going to quickly say thank you so much. Really wonderful presentation.
Thank y'all.
I'm going to wrap up really quickly here. We have 2 upcoming webinars for those of you who would like to join us at noon. On May 2nd, we're going to have Dr. Katerina Aganastu talking about current trends in individualized food allergy management. And we're going to have Dr. David Golden join us for venom allergy and other kinds of insect sting allergy. He's going to be joining us on March 21st. They're both big experts in their field, so I hope you'll join us. Thank you again, Dr. Hoyt. It was really wonderful having you. Hope to have you again sometime soon.
Thank you.
Bye, everybody. Have a good one.